Good afternoon, everyone. Today, my topic is about 8.5 syndrome, which is a rare neuro-ophthalmic presentation due to lacunar infarct as a cause. Coming to the introduction, these brainstem lesions are typically rare due to the presence and they present with difficult distinguishing clinical features due to the involvement of various nuclei and various pathways that coordinate sensory and motor functions. Here we present one such case with right horizontal conjugate gaze movement palsy along with ipsilateral peripheral facial nerve paralysis indicating 8.5 syndrome. The patient, a 62 years male, comes with the complaints of diplopia, which is sudden in onset, non-progressive and binocular. Horizontal separation of images is more towards the right side. It is associated with giddiness, headache and vomiting. Patient also complains of difficulty in closing his right eye, deviation of the mouth to his left side. He is a known case of type 2 diabetic mellitus and systemic hypertension since 5 years on irregular medications, and he is non-alcoholic and non-smoker, and family history is not significant. General physical examination showed elevated blood pressure of 170 by 120 millimeter of Hg, and the remaining vitals are within normal limits. Systemic examination, apart from the cranial nervous system, which shows 7th cranial nerve palsy symptoms, the rest of the systems are within the normal examinations. Ocular examination shows erect head posture with the orthophoric eyes, and the facial asymmetry is present. And right eye shows lag of thalamus, and right side loss of nasolabial folds, and in addition to the deviation of the angle of mouth to the left side is present. Bell's phenomena is intact, and there is no RAPD. Extraocular movement examination showed right gaze palsy, right adduction restriction with left abducting nystagmus, and left adduction restriction. These are the pictures showing right-sided facial palsy element type and right gaze palsy, right adduction restriction with left abducting nystagmus, and the intact vertical movements of right eye and the left eye. The convergence were also normal. Coming to the vision, and color vision and field vision shows normal, and visual acuity is 6 by 6 in both eyes. Next, anterior and posterior examination. Anterior examination of right eye shows lag of thalamus, and the rest of the findings are normal within the both eyes. This is the MRI brain scan showing hyperintensity foci with diffusion restriction and ADI reversal in the tegmentum of the right hemipons, suggesting of acute lacunar infarct in the tegmentum of the right hemipons confined to the basilar artery. The blood investigation profile showed elevated GRBS level and elevated total serum cholesterol level, and the rest of the is like serum electrolytes, liver profile, and everything was in the normal limits. And the provisional diagnosis is right 8.5 syndrome due to lacunar infarct in the dorsal tegmentum of right hemipons. My intervention is routine eye care with lubricating eye drops and eye ointment at bedtime and occlusion of the right eye. Next, physiotherapy to improve the facial nerve palsy symptoms. And patient was referred for the neurological review, and for which he was treated with anticoagulants, antiplatelet drugs, insulin, and antihypertensives for the systemic conditions. Later, patient is discharged with oral medications and advised neuro rehabilitation and regular follow-up. A follow-up done was for 3 months, and for every 2 weeks, patient is reviewed, and patient showed improvement in the facial palsy symptoms. Facial palsy symptoms were improved earlier than the improvement in the extraocular movements, and the diplopia is symptomatically improved. These shows the extraocular movements after the 3 months follow-up. Coming to the literature review, this is a rare case which so far 27 cases have been published. Among those, 18 were due to vascular, 4 were due to autoimmune such as multiple sclerosis, and 3 due to hemorrhagic stroke, and 1 due to gained cellular arteritis and pontine tuberculoma. Rarely, trigeminal neuralgia with 8.5 syndrome has also been described. These are ischemic vertebrobasilar strokes, nearly comprises of 23% of all ischemic strokes of the brain, and brainstem infarcts are responsible for among 11%. Of these ischemic basilar infarcts, 27% occur in the pons. The main pathology is leading to pontine infarction is basilar artery arthrothrombosis or perforator diseases. Pontine infarcts limited to the tegmentum are mostly caused by the small vessel disease or are seldom associated with basilar artery stenosis. Embolism is usually associated with infarct in other parts of the brain and is an uncommon cause of isolated pontine infractions. The etiology related to these lesions include hypertension is the most common cause of 73.5%, diabetes of 48%, cigarette smoking include 30%, and alcoholic consumption is 40.2%. Hyperlipidemia constitutes for 20.6%. Next, clinical implications and take-home messages. As the stroke is the most commonly seen cases, and it is the 30 million cases are involved worldwide, and India is experiencing 1.9 million cases in 2019, and it became the 4th most common cause of death in the recent times. So, the interpretation of the eye movement abnormalities and clinical and ophthalmological examination plays a clinical more important role for the precise diagnosis of the lesion and management, thereby decreasing the morbidity and mortality outcomes. And MRI plays a major important role, and it has an advantage over CT in the detection of these lesions in the acute ischemic stroke. And the only preventive measures available for this is strict diabetic mellitus and hypertensive control. Thank you.
So it is 8.5 syndrome.
Why are calling 8.5
Seven,
syndrome?
seventh nerve plus 1.5 syndrome.
Yes.
Yes.
Now, how do you know which side is the lesion?
Right PPRF and
Right gaze is paralyzed,
Yes,
so right paramedian pontine
so
reticular
we are using
formation
right
is
PPRF.
affected. Okay? If the right-sided paramedian pontine reticular formation is affected, the left adduction of the right eye is restricted. Means what?
Total.
The adduction, adduction of the right eye to the left is restricted, correct? Which means that the impulse goes from sixth to the third nerve, or it comes down from third to the sixth nerve.
Sixth to third to medial longitudinal.
It is an ascending impulse.
Medial longitudinal.
It's not a descending impulse. That is one of the characteristic features of medial longitudinal fasciculars, is that the lesion, the impulse ascends from sixth nerve to the third nerve, not the other way around. Okay?
Yes, sir.
So seventh nerve is affected and 1.5 syndrome is there, so it's called 8.5 syndrome.
Yes.
Nothing great about it. Yes?
Yes, sir.
With the MRI, all these things become child's play.
Yes, sir.
You don't need to use your brain.
Yes, sir.
Yes?
Clinical.
Do we need to surgically intervene in these cases?
For
For the
lag
squint
ophthalmos,
part?
we can intervene, like, apart from that, not much more.
Uh,